Thank you all for joining us today. My name is Vito Garrity. I'm the Senior Program Manager here at NHMA, and I would like to welcome you to the second session of our biomarker testing webinar series, Improving Access to Improve Care. I would like to thank Amgen for sponsoring our webinar series, as well as our speakers, Dr. Narjust Florez, Devon Adams, and Juanita Segura. So just a few housekeeping items all of you will be very familiar with. Your microphones will be muted, but please feel free to use the raise hand feature if you would like to be unmuted, or you can type your question into the Q&A box. We like to leave the chat box open for any comments. So if you do have a question, we do encourage you to put that in the Q&A box. We will address that at the end. This session today will be recorded, and we will house this on the nhmamd.org website and also our YouTube channel. The recording and the slides will be sent out about 1 week after the event. So a quick rundown of the agenda today. We will have an overview of biomarker testing from Dr. Florez, a quick legislative discussion from Devon Adams, and a roundtable discussion with our speakers and Juanita. And then at the end, we will have a Q&A from the audience. The learning objectives are to educate health advocates about biomarker testing among Hispanics with cancer, and to discuss policies that are potential Illinois state solutions to barriers of biomarker testing. So without further ado, I will hand the mic over to our first speaker, Dr. Florez. We're very interested to hear your presentation today. Thank you.
Hi, everyone. Hola, buenas tardes. So I'm going to be talking about biomarker testing. This is as a whole. I am a thoracic oncologist, so most of the information that I will share is in thoracic, but this applies to other cancers. And I have a particularly focus on how this is important to the Hispanic Latinx community. So Vito, let's move to the next slide. So it is time to take action about Latinx cancer care. We continue to document disparities, but it's time to take action to improve the care of all our patients. Next slide. So cancer is the leading cause of death among Latinx and Hispanics, accounting for 22% of death. In comparison with the rest of the population of the majority group, which is cardiovascular disease, Latinos, the leading cause is cancer. The number one cancer death in Hispanic women is breast cancer, and in men it is lung cancer. One of the challenges that we have is that patients with Latinx Hispanic patients are often not referred to palliative care and receive suboptimal care. Next slide. Cancer health disparities in the Hispanic Latinx community exist from lung cancer screening, breast cancer screening, cervical cancer screening, all to the moment of death. As we saw in the previous slide, only 2.2% patients that were Hispanic with stage 4 lung cancer were referred to palliative care between 2009 and 2019. This is analysis that was done from my lab, and we know that early referral to palliative care assures that our patients with lung cancer live longer and better, but we couldn't even reach 5% for Hispanic patients. There are disparities documented in the type of cancer, diagnosis delays. There are disparities in cancers that significantly affect the population at higher mortality rates than the majority group. There are many challenges in survivorship and access to clinical trials. So cancer health disparities for the Latinx Hispanic community exist from the moment of diagnosis to the moment of death. Next. One of the challenges with studying cancer care in Hispanics Latinx is that we are a very heterogeneous group. We are the result of colonization and migration patterns. So this bias, a Latino or Latinx, as many of you know, is from Mexico to Argentina, part of Latin America. But genetically, we're quite heterogeneous group. And we're also all clumped together. I use my family as an example. My mom is Colombian. She has blonde hair, light skin. My father is Dominican, has coarse hair, darker skin. But we're all classified as Latinx or Hispanic, but we're very, very different. In addition, sometimes in large databases, Hispanics or Latinx are misclassified based on surname. What this means is if somebody who has a Latin last name sometimes is classified as Hispanic or Latinx, when in fact they may not be. So that's one of the challenges about studying cancer care in Hispanics. Also, Hispanics and Latinx migrated or remain in their land based in a different background. So Puerto Ricans and Dominicans are high prevalence of population in New York. Venezuelans like me and Cubans, there's a high number in Florida, Central Americans in California and those coasts. So even as a heterogeneous group, we have different distribution in the US. Next slide. One of the big challenges for the Latinx Hispanic population, which is 18.5% of the US population, and it's suspected that in 2030, 1 out of 5 people in the United States will self-identify as Latinx or Hispanic. And let's all remember that 2030 is only 7.5 years from now. So 1 out of 5 people in the US will self-identify as Hispanic or Latinx, meaning the problem of cancer health disparities in the United States for Latinx is highly prevalent. And one of the challenges that we see is language barrier, in which we lack understanding about the importance of bringing an interpreter when talking about cancer care. I appreciate that some people may have taken Spanish in high school, but that is not enough Spanish to talk about cancer care for a patient in which English is not their first language. And sometimes patients are labeled as poor compliant or lack of understanding, but what is existing is a language barrier and the appropriate interpreter services were not used. Next slide. Finally, as we talk about cancer care in Hispanics and Latinx, this is a study from my own lab that is 4 years old, but is still unfortunately relevant. We evaluated minority populations recruitment and the 7 most prevalent cancers in the United States, including lung cancer, breast cancer, prostate cancer, melanoma, renal cell carcinoma. And we found that there is lack of representation of nuestra gente or people into clinical trials. We collected and calculated something called the ejection fraction, which is the result of the number of cases for that certain population and the number of patients being included in the clinical trials. Hispanics recruitment fraction was 0.4% compared to the majority group. It was the lowest group before Native Americans. So Hispanics are less likely to be recruited in a clinical trial compared to Blacks. And why is this important? Well, clinical trials allow patients to get access to drugs before FDA approval. It also data that was presented in 2019 shows that patients with lung cancer that are recruited into a clinical trial, they live longer compared to exact match cohorts due to the close follow-up. So we are holding life-changing treatments for our Hispanic patients as they are not given the opportunity to participate in clinical trials. Recent data shows that if a minority patient, meaning a Black, African-American, Hispanic, Native American, are offered the opportunity to be in a clinical trial, they're most likely to participate. So the myth that the patients are not interested is not true, because when patients are asked, they're likely to participate. So this whole perception that that minority patients will not participate in clinical trial is not based on evidence. Next slide. So why is biomarker testing? Why do we keep talking about this? So I explained to my patients this way. Biomarker testing is finding the key for the right lock. So what that means, the cancer is the lock. We need to find out how to open the lock. In order to do that, we need to find out what if you have a biomarker. We won't be able to open the lock at least we had the right key. And this is true for breast cancer. Those biomarkers include estrogen receptors, progesterone receptors, HER2 status, and other like PI3K kinase mutations that allow us to use the right drugs for the right patients. It's also true for cholangiocarcinoma, which is a very common cancer in Latinos, with new therapies and targeted therapies being approved for cholangiocarcinoma. If you don't do the biomarker testing, the patient, how are you going to know the patient is getting the right treatment, that you have the right key? And for lung cancer, 50% of the patients with lung cancer have a target mutation. Next slide. Let's put things in perspective, because I'm a physician investigator, but everything I do is based on patient care. So this is one of my real life patients, 44, non-Hispanic white female. She's a software engineer. She's married with 2 healthy children, never smoker. She has some distant secondhand smoke. She presents to the ER due to difficulty breathing. And a CT scan shown below, click next, Vito, we have an animation, shows that she has a large lung mass and she has multiple nodules in the entire lung fields, left and right. Next slide. After the ER visit, a PET scan is obtained and it shows that there's a liver lesion. So unfortunately, the patient has a stage 4 cancer. Next slide. She gets a bronchoscopy to identify what kind of cancer it is, and it shows a mucinous adenocarcinoma, TTF1 positive. We have PD-L1 or 90%. You can click Vito. So what do you do next? You know, in this patient, the PD-L1 is very high. She can get immunotherapy. But we're dealing with a young patient that never smoked. We need to find out what is the key for her luck. Does she has a biomarker? Instead of jumping and treating her with immunotherapy. Next slide. We have to wait because not all results come at the same time. Next. Well, this patient has an EGFR mutation, so we found the key. We did next gene sequencing. The issue is that next gene sequencing takes several weeks compared to PD-L1 that takes a few days. Next slide. Next click. So this patient has an exon 19 mutation. Data shows that patients that are treated with the appropriate treatment, with the appropriate targeted therapy, will live longer. This is a compile of patients in which you can see obviously that the patients on the targeted therapy, they live longer because they're in the appropriate therapy. Next. But it's not only about living longer. It's also about how you're living. The quality of life for our patients is extremely important. That patient I just talked to, she ran the Boston Marathon while on targeted therapy. Could she done that if she was getting regular chemo? I doubt it. She continues to work full time as a software engineer. She's raising her 2 children and is doing more exercise than I am. So that's an example that's not about our patients living longer, it's about living better. Next slide. So let's take an alternative pathway. This is another real patient. A 42-year-old female, remote smoking in college, like she used to smoke when she would go out, runner, an associate professor of economics, highly educated. She's diagnosed with lung cancer at an outside facility, and she had a high PD-L1, so she was started in chemo and immunotherapy. Click next. She didn't do well with the chemo immunotherapy. The tumor wasn't shrinking. So she came to me as a second opinion. And I wondered, what happened? Where is the biomarker testing? And it wasn't done. So I'm like, let's do a liquid biopsy right now. And let's find out what kind of mutation you may have or you may not have. I need to know. She already had significant side effects from the immunotherapy that I was trying to manage. The liquid biopsy came back and she had an ALK rearrangement. And I started ordering her targeted therapy. She died from complications of the chemoimmunotherapy and never received the appropriate treatment. Patients with ALK rearrangements, the median life is 6.8 years. 6.8 years, and that's with all drugs. Not treating this patient appropriately got her life to 6.5 months after the diagnosis of lung cancer. she didn't receive the right treatment. I want you to see biomarker testing like antibiotics. Will you treat MRSA with the wrong antibiotic? You won't, right? We won't dare to treat a MRSA infection with the wrong antibiotic. It's the same concept here. Without biomarker testing, we are not treating our patients right. Next slide. I'm almost coming to the end. This is an example. Lung cancer is no longer what it used to be. 50% of patients have a target mutation for which we have a drug. It is expected that a new drug will be approved for HER2. That's 52%. And now we are developing new drugs for NRG1. So that would be 54% in a year for now. So biomarker testing ensures that patients get the right therapy. Next slide. So, right, this is so important. I'm not gonna treat MRSA with the wrong antibiotic, right? But we're not doing well. This is an updated data from 2021 in which you saw all those biomarkers, many of them, right, around 8 or more. Right now, only 50% of patients are getting 5 biomarkers tested. 50% of patients. Next slide. And when it comes to minorities, it's even worse. This is a study by Dr. Bruno, one of my collaborators, that shows that Black men were significantly less likely to get tested. And that's assuring that our patients are not having a good life and they're living less. We're treating MRSA with warm water if we are not doing biomarker testing. Next slide. You can click on everything video. I like animations, people. So that study shows that biomarker testing, next video, was associated with clinical trial participation. So click next. So everything is connected. If we don't test our patients for biomarker, it's unlikely that we're going to clinical trial. So it's unlikely that we're going to improve the representation of Hispanics and Latinx in clinical trials. It's all connected. Next slide. So the question is, who is this responsibility? Is it me? Is it my neighbor? Is every healthcare worker responsibility involved in the patient's care? The pulmonologist, the radiation oncologist, the surgeon, the medical oncologist. Because patients sometimes don't reach us, the medical oncologist. Sometimes they have early stage, but now we have treatment. We have targeted therapy after surgery. So it's everybody's responsibility. Next one. Finally, in the era in which we're seeing resistance mechanisms, biomarker testing doesn't end at diagnosis. Patients that have a mutation that progress on targeted therapy also need biomarker testing at the time of progression. Next slide. Finally, what are some of the barriers? There are many issues. One is communication. Sometimes things don't communicate. Insurance coverage remains a big issue. We know this is, it's like, again, treating MRSA with warm water is a big issue. I often have to argue with insurance to get a drug that is NCCN recommended and FDA approved. The turnaround time is very hard. And this is particularly important for rural US. So I work in the Midwest for a long time. And if you have a sample in North Dakota, it has to get to Mayo and Minnesota. That takes a long time. So the turnaround time is also. But I think improving communication and understanding the importance and changes in legislation, like we're going to talk about it, are key. Next slide. I want, you know, for some of the physicians, when you're in the hospital and you don't put in the note that the patient has a DVT prophylaxis, people come and hunt you down, right? So I want biomarker testing, not only in lung cancer, but breast cancer and any cancer that we benefit from, to be a measure of performance for hospitals. Hospitals love to have big ribbons. We are magnet certified. We are whatever top of the US news report. That should be related to biomarker testing. Because if you're not doing the appropriate biomarker testing, then are you really doing optimal care, right? And also, it needs to be linked to reimbursement. Next slide. This is the end, but I'm going to summarize. For cancer, biomarker testing is the door to precision oncology. we cannot practice precision oncology unless our patients are appropriately tested and they are receiving the appropriate treatment. Why is this important? Because cancer care now has become statewide. You cannot do immunotherapy and then switch to osimertinib. You need to do it in a way that reduces toxicity. So the patient needs to go first in the targeted therapy. First needs to receive that key for the lot. I hope this is helpful. And we can move to the next part.
Dr. Florez, and I apologize to everyone. Thank you, Vito, for taking over at the beginning. I had technical difficulties getting onto this webinar, but I am the moderator here, Elena Rios, President and CEO of the National Hispanic Medical Association. Very glad to be here. And I wanted now to introduce our legislative expert, Devon Adams, Senior Analyst, Policy and Legislative Support, Emerging Science with the American Cancer Society Cancer Action Network. Devon.
Thank you, Dr. Rios, and what a great setup, Dr. Florez. I'm definitely going to use your key to the lock analogy from now on when I'm talking about biomarkers, so I hope you're okay with me stealing that. For those unfamiliar, ACS-CAN is the policy affiliate of the American Cancer Society, and we advocate for evidence-based policies to support cancer prevention, detection, and access to care. And our staff and volunteers work in every state, territory, across the country on federal and state policy. Biomarker testing is a really big priority for us because it's all about connecting patients with the most effective treatment for their cancer. Next slide. Dr. Florez did a wonderful job highlighting the benefits of biomarker testing and improving patient outcomes and quality of life. But we know that not all patients are benefiting from biomarker testing. In 2020, ACS-CAN released a policy report to explore the barriers to cancer biomarker testing, and we identified several. As you can see, excuse me, with this illustration, there are several steps before a patient can benefit from biomarker-driven cancer therapy, and these barriers can occur at any point along the way. First, there must be reliable, valid, and relevant tests available. Second, patients will often need a biopsy or, if appropriate, a liquid biopsy for biomarker testing. Third, healthcare providers need to be aware of what tests to utilize and when, as well as how to utilize the test results in caring for their patients. And fourth, we know that insurance coverage is an essential component for patient access. Finally, healthcare facilities need to be equipped with the appropriate testing infrastructure. One of the biggest opportunities that we saw to addressing barriers lies in addressing that coverage, that insurance coverage barrier of needed testing, particularly in state-regulated health plans and in Medicaid. ACS-CAN conducted a survey of 315 oncology providers to get their opinions of what are the barriers that they were seeing in performing the recommended biomarker testing. And almost 2/3 of respondents reported that patient insurance coverage for desired biomarker tests is a significant or moderate barrier. And we also saw this theme of insurance coverage being a barrier come up in some of the open-ended responses to some of the questions that we answered. Speaking of Illinois, there's a 2021 study that I was a part of that found that 88% of Illinois residents who were in fully insured commercial plans were in plans that were more restrictive than the National Comprehensive Cancer Network, or NCCN, guidelines for multi-gene panel tests for breast, non-small cell lung cancer, melanoma, and prostate cancer. So a large portion were in plans that were more restrictive than what the guidelines recommended. Next slide. So to address this barrier, we developed disease-agnostic model legislation to require more insurance plans, including Medicaid, to cover biomarker testings for the purposes of diagnosis, treatment, management, or monitoring of an enrollee's disease condition when the test is supported by medical or scientific evidence, or if the tests are supported by those guidelines. This legislation was developed in collaboration with many partners, including patient groups and provider associations. Next slide. So what's happening in the states? Well, we've had some recent success. Illinois was actually the first state in the nation to pass our model bill. This bill was championed by Representative Mary Flowers and Senator Antonio Munoz. Illinois was followed by passage in Louisiana, Arizona, and as about 3 weeks ago, Rhode Island. We still have active bills in California and Ohio, and the bill was also introduced in Minnesota, Washington State, and New York, with additional states coming in 2023. Key to our success has been educating lawmakers to help them understand the problem and the potential opportunity that we have. Also, involvement of patients and healthcare providers who share their stories, which really help to get lawmakers excited about this issue. And of course, collaboration across patient provider groups to highlight broad support for this really crucial and needed action. Next slide. ACS Can has several resources on our fightcancer.org/biomarkers to really set the stage for our campaign that we have going on throughout the states to really address that barrier when it comes to ensuring that when there's evidence, when the guidelines say that a patient gets testing, needs biomarker testing, that there is no longer that barrier of insurance standing in the way. Next slide. And then I think now we'll have our roundtable discussion.
Yes, and for the roundtable discussion, I want to invite the audience to put any questions for the two speakers that we had on the Q&A box at the bottom of your screen. And I also want to introduce a patient that we have today to join us, Mrs. Juanita Segura. Thank you, Juanita. Let me ask you the first question, okay? And please.
Okay. Hi.
Hi. Can you tell us where are you? Where are you from?
Well, I live in Northwest Indiana, so it's a small city that is literally outside of Chicago, but it's in the state of Indiana, and my city is literally called East Chicago, Indiana. But Chicago, yes, but Chicago is my city. It's my backyard. So I go and see my oncologist and my team. They're at the University of Chicago Hospital.
Oh, okay, great. I know Indiana is a pretty rural state, but that's good that you are connected to Illinois.
We're north, so we're more urban, I guess you want to call it.
Metro area.
Yeah, metro area, yes.
So what was your experience with receiving biomarker testing? As talked about a lot of good things, but just briefly, did you know that it was biomarker testing, and can you tell us what you had to go through?
So yes, when I was diagnosed back in 2014, it was a shock for all of us. So I really didn't know about biomarker testing. I really didn't do any research because I was just trying to, being, diagnosed with the devastating news like that. You're just trying to figure things out. So actually it was my husband, Steve, that he was a champ. He jumped on, the web, and he just started searching everything about lung cancer, anything. And so he learned about biomarker testing. He learned about targeted therapy. He learned about all that stuff. And he had a notebook and he wrote everything down. And so when I was diagnosed here at my community hospital. Well, of course, they don't know anything about that. They just, chemo, radiation right away. And so because of our ignorance, I did chemo and radiation. I went to another hospital, a cancer center in Illinois, and they did the biomarker testing there. But I had to have several bronchoscopies just to get enough tissue. So once they got it, yes, and they send it off to the pathologist, it literally, and then this is back now, I was diagnosed in November 2014. So by December of 2014. That's when everything happened. It literally took 6 weeks for me to get my results. If I would have got my
Oh, you're on mute.
chemo, radiation, and went straight into targeted therapy, because after 6 weeks of getting the results, I'm ALK positive.
Yeah.
So there's a lot of stuff that I could have avoided.
Yeah.
But unfortunately I didn't. And so there's a reason, I believe there's a reason to share my story and to educate others with biomarker testing. And that's what I do as a lung cancer advocate.
So let me thank you for that. And as was mentioned earlier, timing is everything. And knowing the right treatment and the right, and the testing that goes along with that is important. Dr. Florez, you talked a lot about all the details. I'm just going to ask you some overall questions. What do you think are the difficulties in getting biomarker testing? Where is it? The hospitals? Is it the doctors? Is it the medical education? What do you think are some of the barriers or difficulties for getting biomarker testing, into the hands of our doctors? And I know it's going to be legislative too, but I want to ask you, what do you think are some barriers that some of our policies could address?
I think the issue is multifactorial. I don't think there's one thing that is preventing, for patients to get adequate testing. I think the number one is the lack of awareness of the differences in survival and the differences in quality of life. A patient that goes on appropriate target therapy for ALK positive, like Juanita, can live, the median is 6.8 years, but can go 9. I have a patient that's 11 years out, compared to chemotherapy, which back in the day used to be around 6 to 13 months. So you can see the difference there. So lack of awareness. The second is insurance approval. It still becomes a big issue, not only about the biomarker testing, but also getting the drug approved. Even if the patient has that key, you have to argue. And it honestly, to you, Dr. Rios, it has becoming more and more difficult over time, more and more peer-to-peers to make the process of treating the patient appropriately more difficult instead of easier. Another thing is also resources. A lot of small hospitals do not have in-house testing, and that delays the turnaround time. Like I'm at Dana-Farber in Harvard. My turnaround time is quick. I have my own assay, very different. And we need to remember that 80% of patients with cancer are treated in the community. They're not treated in an ivory tower like I am. So turnaround time, insurance, lack of awareness, and poor communication. Right now, with the current approvals, almost every patient besides stage 1A with lung cancer should be tested for biomarkers.
Yeah. Okay, great. Let me turn this over to Devon. Devon, we have some, at least one question here that really asks about the role of clinicians to help the situation to get more of their patients covered. And I want to ask you, as a leader in the legislative front, and especially in Illinois, where Juanita's from, could you tell us how could you increase the role of physicians and other clinicians, pathologists, hospitals? How can you tell us the story, the backstory, and how do you include the healthcare system in helping the legislative leaders to get these types of legislative policies passed?
Sure. So I physicians, other medical professionals are key to really passing laws like we did in Illinois and in several other states. And I think what the most impactful thing is similar to what we're doing here. We have a respected physician telling and demonstrating and speaking to her experience how beneficial biomarker testing is. And just like you pulled up, those x-ray slides or the CT scan slides showing the difference between pre-treatment and post-treatment, those type of examples are powerful when lawmakers see them, because it's a really easy way to show the benefits of testing. And also having patient advocates like Juanita speaking to this as well, sharing her experience, having the doctor and the patient, like that combo is really, really powerful. And also having physicians speak to their barriers that they're experiencing, particularly the barriers that can be solved with a legislative fix, like, you know, the insurance coverage. So hearing directly from providers was really key, you know, to us passing this legislation. And when lawmakers hear from medical professionals, it really, really can go a long way.
And Juanita, let me ask you, you mentioned that you were in a community hospital at first, and that after going to I'll just say a university hospital or a larger hospital, that you found that there was more information about better therapy, like biomarker therapy, biomarker testing. What do you think needs to happen in your communities to get your community hospitals to be at the standard of the university hospitals?
Well, Dr. Rios, I've been asking that and trying to make a difference for 8 years now. The good thing about it here at the hospital that's literally in my backyard in Northwest Indiana, because I was diagnosed there and because I kind of blew up as a lung cancer advocate, and I did so much and I continue to do so much, that they kind of know me, and they started doing, right after I was diagnosed, they started doing low dosage CT scan. I think they still have it for a small fee. So you could pay it, I think it was $49 or $59. You didn't have to go through your insurance. And, you know, they just somehow, some way, we got to figure out a way to educate oncologists in these small cities and towns near me and throughout the United States, because they don't know. The first thing they do is literally, okay, chemo and radiation. Wait, hold up. Don't you want to go back to your office and do some research about lung cancer? And then we go from there, or maybe call oncologists at bigger universities like University of Chicago Hospital or Rush, or even, let's say, MD Anderson, or even Mayo Clinic, and talk to someone about, okay, I just had a patient here in little old town USA with lung cancer. What do you recommend? What should be my next step? Don't just throw them into chemo and then expect that they're gonna be cured, or, you know, the tumor's gonna shrink, because that didn't happen to me. Chemo just made things worse, and radiation. I ended up with radiation pneumonitis and ended up at the hospital at University of Chicago Hospital there for a week. Yeah. So it's very important to figure out a way somehow to get to these community hospitals, to these oncologists, to these other people, even if we start with pulmonary specialists. I can't even talk today. Pulmonary specialists, because they deal with the lungs. Even if we start with them and say, hey, you know, you might get a patient that was diagnosed with lung cancer. Here's some information to guide them to the next step. And thank goodness that I had a pulmonary specialist that was on top of it, and he kind of knew, and he's the one that kind of guided my husband and I, okay, this is what you need to do, this is where you need to go, and so he was already aware, but not many are.
So let me follow up on that, and this is another question from the audience. Dr. Florez, how do you think more doctors involved in cancer care, lung cancer care, let's say that they're primary care doctors or they're oncologists, as Juanita was saying, but they're not in big university hospitals. How do we get the message out to them? And also in medical education with medical schools, just understanding that there are new treatments that are available that, again, need to be thought about, you know, in terms of teaching the next generation to start understanding where to get new information. New information happens every day. So, you know, we've got to figure out how to best educate our doctors on how to increase their efficient time in looking for new ways to treat their patients. In this case, biomarker testing. How do you think biomarker testing can be elevated and be, you know, taught across the spectrum, from the community hospitals to the oncologists, in university hospitals, and also in medical school?
So the first thing I want to make aware is that the lung cancer and a lot of biomarker studies have been very quite fast. In 2020, we have 7 new approvals for lung cancer, and that's the year of the pandemic. So we need to remember that general oncologists in the community, they are treating breast cancer, anemia, they're treating lung cancer. So the data is moving fast and they work extremely hard. I give a lot of credit to our community oncologists because I only treat lung cancer and the majority of my patients are women because I specialize in women with lung cancer. So I need to be good at one cancer and a majority of one gender, right? That's easier than trying to, treat prostate and breast and multiple myeloma. One of the things that to improve awareness about biomarker testing, we're doing right now, which is webinars and disseminate the information through different channels. Learning has changed, right? Back in the day, when I was a medical student and Dr. Rios, you may remember, we used to get the paper journal. And if you didn't have the paper journal, there was no other way to read the article. But now we are learning to social media, Twitter, Facebook, the news, the newspapers, and the journals still. So making sure that all the teaching is evolving as the research is evolving. Because I think cancer teaching is still a little bit behind. I'm a teacher myself at the medical school, and I think medical students are often sheltered for some of these cancer data. It's like, oh, it's too complex from them. But those are the doctors that are going to diagnose our patients, right? So we need to stop sheltering people from oh no, cancer care is so complicated. I remember being a resident and I knew I want to be an oncologist, but I still have to push to take care of patients and with cancer, right? They're often in a separate floor. They're often treated by MPs and the attendant. So the trainees don't get experience. So one of the things that I'm working with ASCO on it is early exposure of trainees to cancer care, including biomarker testing. So I think that's very important. And finally, I have to say that the power of one, we often think that we need a large systemic change, which we do. But us as providers, caregivers, and patients, we have a lot of power too. Through teaching to advocating. I often go to the Hill to advocate. Back in the day, it was in person. The last 2 years has been virtual. But advocating, talking to our representative to have bills like the one in Illinois, which is actually a wonderful thing for a thoracic oncologist that has seen people die too soon just because they didn't get the right biomarker. So more teaching, getting them involved in oncology early, advocacy, and also providing resources for the community oncologists that are pretty cramped right now, trying to see all patients.
So you mentioned ASCO, and Devon, let me ask you how you work with ASCO. Is is an association of the clinical oncologists, and very important for everybody to know how our organizations that are in organized medicine have the role of developing advocacy for important issues like biomarker testing. Devon, could you just maybe use ASCO as an example? And then I want to ask you, how can NHMA, National Hispanic Medical Association, be brought into this issue? And I'm going to say we have oncologists within our membership that tend to treat more Latinos because they're Latino doctors, like Dr. Florez. And, there's a role for us in advocacy, especially because we focus on the Latino patients. But let me just ask you about the role of organized medicine with the American Cancer Society's legislative efforts and how we can be more involved.
Sure. So groups like ASCO and several other professional organizations were really key to us developing our legislation, amount of legislation which has passed in Illinois and other states. So hearing directly from them, because they're on the ground treating patients, hearing directly from them the barriers that they're facing, and particularly the insurance barrier was really key. Going to provider groups and hearing directly from them. And I'm so glad to hear that, Dr. Florez, that you go to the Hill and you advocate, because once again, that's very powerful. groups like ASCO, NHMA are highly respected groups. So we wanted to make sure to go to them and bring our legislation to these type of professional organizations to get their feedback and their endorsement, to make sure that, we were on the right track to, improving, some of the barriers. And I think that NHMA can serve a huge role similar to, the other professional organizations and advocacy, because especially if, especially with given the communities that are, underrepresented in trials or not getting access to different treatments and therapies. So I think, definitely NHMA can play a huge role in our advocacy efforts to really improving access to biomarker care across the U.S. We got some victories in 4 states so far, but there's many more to go and many more barriers to address.
Thanks, and yes, we want to work with you. So let us know how we can best serve, signing letters or providing doctors to testify, that type of thing. But getting back to Dr. Florez, I really want to just, I think it's so great to see a few states reaching the, let's say, the turning point for insurance companies to provide the, to have to be able to provide the reimbursement for doctors for their biomarker testing. What do you think are some of the difficulties in getting biomarker testing approved by insurance? Why don't they want to do it? Or what can we do to promote the idea that it's a good thing, and so that more state legislators, will see that it's not an uphill battle?
I'm going to be very straightforward, like I always am. It is cheaper to give chemotherapy than targeted therapy. It is cheaper. The drugs are off patent. Carboplatin has been around since 1995, probably before that. So that is one of the challenges. It's cheaper to give chemotherapy, but that shouldn't affect patient care. Like in other nations with universal healthcare systems, right? The financial aspect doesn't drive patient care, and it shouldn't. Because when we all went to medical school and swear or oath, there is not like a star that says, oh, you should go for the cheapest one. No, it's best treatment, longer living, and better quality of life. Another thing also, I think there is a delay too. There's a delay between guidelines, because the guidelines are changing very fast, and insurance that have to get their information together for approval. There is a lab there. Another to help for that, I'm one of the members of this group, ASCO, which is the American Society of Clinical Oncologists, we create guidelines, have created something called living guidelines, which are guidelines are being updated frequently as treatments change, because research is moving very fast. And everybody should move at the same speed that research is moving, because that's what assures our patients live longer. So you have 2 answers there.
Okay, so Devon, let me just ask you about in terms of legislation at the federal level, what are the opportunities to push forward with Medicare and with Medicaid that are under CMS for federal level insurance? They are the federal insurance programs of the country. And what's happening with those insurance companies in terms of, in terms of CMS appreciating the importance of biomarker testing, as Dr. Florez said, for quality of life and for longer living, and not just looking at the money.
So when we did our analysis of some of the barriers, where we really saw the insurance coverage barriers was, directly, linked to those state regulated plans and Medicaid. We know the Medicare population tends to have better coverage for biomarker testing. There are several Medicare national coverage determinations and local coverage determinations that do a pretty good job of taking care of that population. But if you dive into the research, it's really in those state regulated plans and particularly in Medicaid, where there are barriers related to insurance coverage, where there's research that shows that people who are in Medicare, who have Medicare coverage, are less likely to get certain guideline recommended testing for biomarkers. So that's why it was really key, and why we decided to wage this state-by-state campaign to really focus in and hone in on the populations we know are less likely to get tested, or more likely to experience those barriers to testing.
Okay, well, thank you for that, because I think it's important. And Juanita is an example of an advocate for our communities, of not only Latino communities, Black communities, our communities that tend to be on Medicaid, those that have a lower income. You have to have a lower income eligibility for Medicaid. And hopefully we can have Medicaid expansion for the whole country. But Juanita, just to ask you, what is your role as an advocate? How would you encourage others, who, especially those who are survivors of cancer, to get more involved?
Oh my goodness, Dr. Rios.
Just one thing.
I literally have a resume with all the advocacy work I've done in the past 7.5 years. Now I can add this one to it. You have to advocate for yourself. You have to, yes, getting diagnosed with lung cancer is a devastating, heartbreaking news, but don't stay there. Do your research, ask your oncologist or your team or your doctor questions. And I always tell people that reach out to me, I always tell them, ask about the biomarker testing. That's the first thing that comes out of my mouth. And I tell them, get a piece of paper, get a notebook, and write all this stuff down and go talk to your doctor or your team. Biomarker testing is so important, but do your homework, do your research, educate yourself, and advocate for yourself. That's the only way, for me, it'll get better. So I teach them to advocate for themselves and educate themselves, so then they could also help others if they come across someone that was just diagnosed with lung cancer.
Yeah.
So that would be my advice.
Okay. No, thank you very much. And Dr. Florez and Devon, and let me ask you both, do you work with patient advocacy organizations? And is there, or is there one you can mention, for the audience to know about, or is there a role that you see that can be strengthened for biomarker testing with your patient? I know you have patients that can spread the word, but I'm asking about an organized effort.
Yeah, so I work with many organizations. Like Juanita gave me the weakness of this. Many in the lung cancer space, but I also work with other organizations outside of lung cancer, and we in breast cancer, because breast cancer is still the #1 cancer killer for Latinas. So I work with the Go-To Foundation for Lung Cancer, with the Lung Cancer Research Foundation, with Longevity. I also work with the American Society of Clinical Oncology, with the International Association for the Study of Lung Cancer. And I always include patient advocates and patient activists into my studies, because the patient voice should be included in all research studies, because they have a perspective that nobody else can provide. Doesn't matter how many degrees you have after your name, or patients, advocates, and activists have an insight that nobody else can. And that's what I have been working with their groups since I was a fellow at Mayo Clinic a long time ago. So I work with these organizations because we're all combined to push for biomarker testing, because it's the first thing we can do to improve the patient care for all patients with lung cancer.
Great, no, thank you. Devon?
And I'll just add on, just to tell my own organization, ACS CAN, and our, campaign that we have in the States to improve insurance coverage. But we have several other, patient organizations who have endorsed our model legislation. And I think really, when you have patient organizations from different groups all working together, it only strengthens your advocacy when you have these different groups who have coalesced to agree that, hey, this is a problem and this is a solution that we found that we can use to address this problem. So when you have multiple groups on board and are working together, it really can go a long way as well.
Great. Well, I think we're going to wrap up here. I want to just say a few comments about the importance of sharing today. We heard from Dr. Florez, an oncologist. We heard from Devon, a legislative leader, and we heard from Juanita, a patient living with lung cancer, who's more than a patient, is an activist, and I would say a community activist. And has lots of, I think all three of you have shared your lifelong interests in pushing forward your, I'm going to say your energy around the importance of biomarker testing to increase life for lung cancer patients. But more importantly, you all have networks. And, you know, we have this program, Vito, is it being recorded?
Yes.
Okay. I think that this recording needs to get out to all of your networks, and especially the patients, and the importance of being an advocate. I also want to thank our Amgen partner today who's supporting the efforts to educate our communities. And, you know, the National Hispanic Medical Association is very interested in doing what we can to support policy education around healthcare, especially for our communities of color that don't get the information. And a lot of problems in our communities, especially not having access to healthcare just in general. And I think it is important to realize that healthcare information is out there in social media and reaching our communities more and more, but sometimes it's not the right information. So we do need our patients, I mean, people that have diseases to see a doctor, whether it's in a community health center or their community doctors. And I think we're all in the same agreement that we want to support biomarker testing for lung cancer patients and for other cancer patients, because it is so important to have better care. And then just a few announcements here from the National Hispanic Medical Association. We have updates here for other activities. We're having a special congressional briefing focused on achieving health equity, especially lessons learned from COVID-19, which really has done havoc for those patients having respiratory problems like severe asthma. And we want our legislators and their staff and national advocacy groups who come to our briefings to know more about the importance of treating patients with severe asthma because of the lessons learned from this epidemic or pandemic. Biomarker testing, we're going to do one more session with Devon, and we will be focused on the importance of improving access to care in Texas. And that'll be August 25th. Sorry, the congressional briefing is July 27. The biomarker testing number 3 will be August 25th. And then we have our COVID-19 virtual briefing, which will be in the evening, and that'll be August 31st. Looks like we have the Surgeon General invited. Not sure about that. Anyway, and then our last announcement here is that the National Hispanic Medical Association has an annual conference, and we're very happy to announce that we're taking it out of Washington, D.C. this year and going to Chicago, Illinois. Juanita, you might want to join us.
Sounds good.
We'll be in Chicago for the party. But we network with doctors from all over the country who take care of Hispanic patients to share ideas on how to increase their education and awareness, and to educate more doctors that are not Hispanic on how to take care of our people with respect, and also with you know, how to communicate better with our patients to make them to get them to come back to get their chronic disease care, especially. So I think that's all I have. Vito, thank you very much, and the staff at NHMA for putting this together. And again, thank you to Amgen. Thank you very much to all of you for attending.
Thank you.
Thank you.